Good evening, everyone. Introducing to you Dr. Marco Becciolini. Did I pronounce it correctly?
Yeah, Becciolini. Yeah.
Becciolini. Okay. So now it's all yours. Time is yours. So go ahead.
Thank you. So thanks again, Jamilio, for this invitation. My presentation is about dynamic examination in musculoskeletal ultrasound, and not only intended as the simple movement or contraction of a muscle. This is a paragraph in Fundamental Musculoskeletal Ultrasound by John Jacobson, in which there is written that a significant advantage of ultrasound is the dynamic capability. This presentation is more a talk that I hope can help colleagues with practical intent tips and regarding cases that I have seen. I am starting with the basic concept as the frequency, the focus, and the depth. And this is a foot, this is and obviously, if we want to check for Achilles tendon, we need to put our probe in like this. But the image that we are going to see is this one. So we have the Achilles tendon, the cardiac fat pad, and the calcaneus. Notice how the focus is put very superficial. But if I want to study more in depth, the more deeper structure, I need to change my depth. I need to change the focus, and I may have to have a trapezoid view to see more structure. And now I'm looking not only at the Achilles tendon, but also at the tibiotalar posterior joint and subtalar joint. We have to remember to use correct acoustic windows. So this is a patient that comes for evaluation of pain at the level of the second metacarpophalangeal joint of the left hand. So with B-mode and Doppler sonograms, we can nicely demonstrate an active synovitis of this joint, but we can also see pointed out by this yellow arrow that there is an hyperechoic spot. If we put our probe in a perpendicular plane than the first plane, we can nicely demonstrate that there is something here, and it was a foreign body. Of course, the history of a patient which referred that she had fallen over a cactus plant lead us to search for a possible foreign body. And we can see this foreign body nicely because we are using a lot of gel. So our sound beam is perpendicular to the foreign body, and it can be nicely seen here. Also note that to have a correct evaluation of a structure at power Doppler, it's important not to press too much. So if you are looking, I'm using also here a lot of gel. This is an article from 2019. This is the technique to evaluate the indirect tendon of the rectus femoris inserting at the level of the lateral acetabulum. And I think this was first described in 2015 by Moreau, and these are this is figures. But the thing that I want to explain is that if we want to check for this tendon, to me the best thing is to follow the central aponeurosis at the level of the proximal thigh. Here we have the rectus femoris, here we have the sartorius and the tensor fascia lata. Then we go up, then we go up. When the muscle becomes small, we can move laterally and follow this aponeurosis so that it inserts as the indirect tendon of the rectus femoris. We can also change the focus to better see this tendon insertion. Patient positioning is important, and for example, if you want to evaluate the neurovascular popliteal neurovascular bundle at the level of the popliteal region, we may ask the patient to flex a bit the leg so that we can see the vein, and then we can nicely compress it to rule out for possible DVT or thrombosis. These are two sonograms. I think 5-second distance between the one and the other. In one, we can see there is no hyperemia at Doppler. Otherwise, in this we can see there is hyperemia at Doppler. The color gain is the same. The PRF, the pulse repetition frequency is the same. Everything is the same, but something is different. Let's see in particular what is different. We have some artifacts, but here is the hyperemia that we are seeing. So basically, in this case, the tendon is tense and is not tense here. So we have to remember that when we check with power Doppler structure, it must be in relaxed states, as tissue contraction will result in compression of the vascular structure, leading to false negative here. Okay. Compression. We've seen a very nice webinar by John Jacobson about the follow-up after surgery in supraspinatus repair or rotator cuff repair. These are two different patients. I think that maybe the most skilled of you can already tell that there is one of the two which is not good. But let's see what happens during compression. We see that here there is no more tendon, there is fluid. Otherwise here the tendon is normal, there are suture, and so here the tendon is intact, whereas here we have a recurrent tear. Sonopalpation is the possibility of ultrasound to compress over a region where we find some abnormalities. These are images taken from this paper, in which there was a patient with a fracture of the two sesamoid bone at the metacarpophalangeal joint. And just remember that there are usually two sesamoid here, one sesamoid here, one is usually here, and one is usually here. Even remember that variants may exist. This is the sonogram in which we demonstrate the fragmented sesamoid with the corresponding CT. In this article, we write that with the pressure with the probe was painful, confirming the diagnosis. This was a patient that came to me for glutalgia, mainly gluteal pain at the level of the right ischial tuberosity. She already underwent an MRI imaging, which was reported as normal. So we had the patient with us. We tried to check the region of the hamstring origin tendon, and we found something that we believe was abnormal. This is the healthy side. Probably in sagittal scan, it can be even better seen. I think that the evaluation of this region, mainly in women, mainly in not athletic people, is difficult. I think that MRI is superior to ultrasound, but I think that we can see that this structure here is thickened comparing to the structure here. This is not a competition if ultrasound is better than MRI. I think that both have their advantage. I think that the main advantage of the sonologists, people who perform ultrasound, is that we have the patient with us, so we can check and concentrate our examination with the symptoms of the patient, and we can also have a look at previous imaging studies to confirm that something is effectively wrong. This tendon is thicker and degenerated compared to the healthy side. Okay. Elastography. Okay, so this is a patient, a nurse, who palpated a firm and our lump at the level of the medial thigh. He had a melanoma, a previous melanoma at the level of the leg. So this is the Doppler image, and I think it's a bad image. So we have a polylobulated, hypoechoic mass with an anarchic vessel, and of course we can use elastography. This is strain elastography, in which we are compressing to see the properties of the tissue. And we can see that this is harder, blue, in respect to surrounding subcutaneous tissue normal, okay? We can have a ratio. We can also have shear wave elastography, which in which is not important that I manually press. And I see that in kilopascal, this lesion is stiffer than normal soft tissue here. But I think that the B-mode and Doppler findings were also indicating that this lesion was likely a recurrence for a melanoma. So I think elastography is interesting. I'm not sure that it can change drastically our diagnosis. I think it's interesting. I think we need to study more to understand. For example, also in tendinopathy, it's not so easily to standardize elastography, in my opinion. But maybe in the future it will be more standardized, and we can have some good cues by elastography. Impingement. This is a patient with a calcific tendinopathy, and we can see this is the subcutaneous fat, we have the deltoid, we have the supraspinatus, we have two calcification with acoustic shadowing, something like a centimeter or so. But during dynamic movements during abduction, we can nicely depict that the tendon can't properly glide at the level of the subacromial arch, likely related to this calcification that we are seeing. This is another patient. This is an anterior axial scan. The probe is placed in this way. This is the subcutaneous fat, the deltoid. This is the long end of the biceps. Notice that it appears hypoanechoic due to anisotropy, so I'm not correctly scanning for it. There is a calcification. This is the subscapularis. This is the lesser tuberosity. And these are the muscles that originate at the level of the coracoid. So we have the short head of the biceps and the coracobrachialis here. Let's see what happens during internal and external rotation. So we can nicely see that this calcification impinge with this muscle here, and sometimes there is some kind of snaps, causing symptomatology to the patient. The Kerven disease is a pathology at the level of the first compartment of the extensor tendon at the level of the wrist, in which there is a thickening of the usually of the retinaculum. There is a synovitis and the possible thickening of the tendon. These are comparative long and long axis and axial scanning, in which we can demonstrate the thickening of the retinaculum. At Doppler, we may found hyperemia even at the level of the retinaculum itself, some fluid here. But I think that dynamic maneuvers are interesting. So this is a long axis, and we can see that at the level of the healthy side, the tendon can glide normally. Otherwise, in the affected side, we can see that the tendon can't glide normally because of this thickening. I personally don't do intervention, so I don't inject. But I think that if I had to inject and I explain the patient that there is a problem and I have to solve it with my injection, I think the patient will appreciate it and will tell me, okay, doctor, let's go straight to the infiltration, and I want to do it. Just to differentiate the Kerven type 1, the previous, with type 2, which is this. This is type 2, in which there is a septum dividing the first compartment tendon, so the abductor pollicis longus between the extensor pollicis brevis. Usually, the affected tendon in the Kerven type 2 is the extensor pollicis brevis. This is the healthy side. We can see the very small retinaculum here. This is the diseased side, in which the retinaculum is thickened, but we can see that at the level of the abductor pollicis longus, the retinaculum is quite normal. So again, long axis and the comparative scan. It's interesting how just a bit distal to the retinaculum at Doppler there is hyperemia, sorry, only encircling the extensor pollicis brevis, while there is almost no hyperemia at the level of the abductor pollicis longus. This is real-time scanning, so we start with this, then we go longitudinal. We are at the level of the abductor pollicis longus, can glide normal, and now let's see what happened with the extensor pollicis brevis. Can't glide normal to do this thickening, okay? This is a 71 years old patient who came for trigger finger of the third finger, yeah. We can nicely depict the thickening at the level of the A1 pulley. We can also depict a cyst at the level or near the A2 pulley. This is a comparative sonogram with the healthy side. So please remember that these sonograms are obtained at 18 megahertz. I think it may be difficult to correctly evaluate a normal pulley at 12 megahertz, but I think also that when the retinaculum is thickened, you can see it also at 12 megahertz, okay? So this is a schematic drawing of what happens. Dynamic maneuver, let us understand that the cyst, this is the cyst, the tendon can glide normal. Otherwise, at the level of the pulley, the tendon can't glide normal. So this is a problem, this is not, okay? Osteochondroma. This is a patient, 19 years old, I think. It was a 19-year-old patient who came for the evaluation of the posterior knee. She already knew that she had an osteochondroma, and this is the MRI that she had. Ultrasound can also demonstrate nicely this. These are, oops, sorry. And these are axial scanning. These are axial MRI, axial ultrasound. And she referred that she has some pain during plantar flexion of the foot. So she was a dancer, and ultrasound can nicely demonstrate the problem. So every time that she plantar flex, the muscle, here is the medial head of the gastrocnemius and here the soleus, goes over this osteochondroma. Another case, a very small osteochondroma at the level of the distal femur, we can see that there is some kind of snapping and sliding of the medial head of the, the vastus medialis at this level. This is a 70 years old, very active man, more active than me. And he is a climber, and he fall during climbing and had this fracture. So he was treated in Florence very well, and he started little by little to have some physical activity. And I saw him at 6 months after surgery, and I think it could tell me that he has pain everywhere. But anyway, he referred that he had pain exactly here. So let's put our probe here and see what's happening. So I wrote that this is the vastus medialis, and I wrote viti. In Italian means screws. So we see that there are 2 screws that are near the vastus medialis. In particular, the distal, during extension of the leg, had some kind of impingement with the vastus medialis. 10 days later, he called me because he referred that he felt like a knife while he was standing up on the pedals biking, and we can nicely see a small hematoma here, and we can nicely understand that during extension, this screw was something like effectively a knife inside the vastus medialis. This is a patient with a previous fracture of the wrist, coming for the evaluation for some pain at the level of the dorsal wrist, especially during flexion and extension of the wrist. At the static examination, we can demonstrate this screw, which arrive very near to the extensor carpi radialis brevis, and this is axial, so this is the extensor carpi radialis longus, this is the brevis, this is a synovitis, a reactive synovitis. During dynamic maneuver, during flexion and extension of the wrist, we can nicely demonstrate that this screw is causing a lesion of the partial lesion of the extensor carpi radialis brevis. Otherwise, in this patient, we can see this screw, which can be found only less than 1 millimeter, and this patient had no symptoms. So this can be normal. Okay. This is quite recent. He's a physio, and he referred me that after running, he's a runner, had some pain and some symptoms like a crepitus in the Achilles during plantar and dorsal flexion. He was worried about a lesion of the Achilles and came to me. So this is a sagittal sonogram which can demonstrate that the Achilles is not involved by a lesion. But this is 14 megahertz. So let's see at 18 megahertz the Achilles in comparative with the healthy side. We see there is a bit, the Kager fat pad is probably a bit more hyperechoic than the opposite side due to edema. But we can see that there is something that we can find here. So it was a paratendinitis, and at Doppler, at power Doppler, we can nicely demonstrate hyperemia peripheric to the tendon, and we can also nicely demonstrate to plantar and dorsal flexion of the foot that in the healthy side, the Achilles can glide quite normal, but here I don't know if you can see it, but mainly during plantar flexion, there is some sort of impingement of the Achilles with this paratendinitis here. And when I had my probe over the Achilles during this movement, I felt some kind of crepitus. I don't know if you have seen some intersection syndrome at the level of the forearm, the first and second compartment, some kind of this sensation. Ultrasound can nicely demonstrate snaps. So this is snapping triceps. This is the first the ulnar nerve that snaps, and then the medial head of the triceps. I usually have this kind of sonogram. Please remember also to not compress too much with your probe, otherwise you will stabilize the nerve, and you may not see the snapping. I want also to talk about snapping hip and extra-articular causes. One is external at the level of the iliotibial band and gluteus maximus. This was a patient that came for a sensation of snap at the level of the lateral hip, and this is what we see, a snap. In this paper, it is reported that the snap is usually anterior, from posterior to anterior. In reality, in this patient, the snap was from anterior to posterior, and I think it's well explained in this paper by Natalie Burrow. And snapping may also occur during hip extension, while the iliotibial band and anterior margin of the gluteus maximus are moving posteriorly over the greater trochanter, just in my cases. In this article, which you can find, they explain the method, how to check for this snapping hip. But I think the best thing, at least for this kind of snapping, is to ask the patient to have to reproduce this snap. Of course, you have to have the patient in front of you, stand up. It's not every time easy, but I think it's snapping can be best seen in this way. Otherwise, in internal snapping hip extra-articular made by iliopsoas, there is a precise movement that we can have the patient to make, so that we can depict this snap. What happened is described in depth by Guillin in this article. This is what happened in depth, but I think that it may be more easy if we follow again this article by Natalie Burrow. We ask the patient to have a Faber position, so flexion, abduction, and external rotation of the hip. The medial fibers of the iliacus muscle, which are these, become confined between the psoas major tendon here and the superior pubic ramus. So this goes here, and the psoas tendon goes up. On returning to normal to rest position, the medial fibers suddenly free themselves from this position and cause psoas major to return abruptly against the superior pubic ramus. So basically this, and the superior pubic ramus goes down. Let's see again, and we can nicely see that the medial fiber goes deep here, and this is the tendon, and it snaps. We may also find some patient in which this movement is not so abrupt, and I would not call this a pathology. Snapping hip may be almost asymptomatic. So usually ultrasound is requested to understand what is happening. So I think that we have to report if we can demonstrate the snapping. Usually remember that this can be seen without any pathology. Sometimes snapping hip may be painful, but I think it's the patient that will guide us, telling us that this movement is causing some symptoms. Also, I think we can find in this case some cases of tendon pathology, which was not present in these two patients. This is again a patient with the calcific tendinopathy of the rotator cuff, so a calcification of the supra and one of the infra in short axis 1 and 2. So we can imagine that they are located here, but during internal and external rotation with ultrasound we can demonstrate that this calcification is causing some sort of snaps with this structure, which is a aponeurosis of the posterior deltoid muscle. Okay. This is a patient with coming for a lump, but we can see that during radial and ulnar deviation, there is some sort of here snapping, and with the static ultrasound, we can demonstrate a ganglion cyst. We can see that it's near the extensor tendon, and during ulnar deviation, tendons are here. During radial deviation, tendons are here. Please note that we have 1 and 2 tendons. Why? Because we are the tendon that are snapping are the tendon for the second finger. So remember that there is also the extensor indicis procus. The extensor indicis procus is important, particularly in extensor pollicis longus rupture. I've seen one yesterday, and please remember to report where the end of the tendon are, but also to report the presence of this tendon, because usually the surgery, the orthopedic surgeon will do a transposition of this tendon to the extensor pollicis longus. Lumps evaluation. So this may be similar to the previous case. We see a cyst, but let's see what happened during flexion of the thumb. So it glides with the extensor pollicis longus. So it was a tendinous ganglion cyst. Okay. This is a patient that came for the evaluation of the of an inguinal lump, and we put our probe at this level, and we say, okay, you have a normal lymph node, don't be afraid, the examination is concluded. But the patient tells us, yes, but I have some kind of pain, particularly when I'm standing up for a long time. I usually can't see the lamp when I am at bed resting. Okay, so have a Valsalva, and we can nicely demonstrate that there was this hernia very near the lymph node. So of course there was a lymph node, but the problem was the crural hernia. Again, always listen to patient, okay? Muscular kinetics. This is fibrotic fibrosis in a previous injury of the rectus femoris. And during contraction of the muscle, we can understand that there is a small concavity created here by this fibrotic tissue. Sometimes, in this case, no, but sometimes you may be asked to rule out for lumps that in reality are pseudo lumps related to fibrotic muscular tissue. This is a patient which was in therapy with anticoagulant and had a complete tear at the level of the neotendinous junction of the medial head of the gastrocnemius with a very, very big hematoma. And in this case, dynamic maneuver can confirm there is no gliding of the medial head of the gastrocnemius. This is the lateral head which can move, and this is the soleus. Again, another patient with an injury. This is the image. Not so sure of what I'm seeing. I'm just pressing to confirm that there is a complete rupture of the rectus femoris, distal rectus femoris at the myotendinous junction distal. Tendon injuries, mallet finger, refer to a condition in which we have a tear of the extensor tendon at this level. It may be osseous with an avulsion or poorly tendinous. In this case, X-ray is enough for the diagnosis. In this case, X-ray can't see the injury. These images are not mine, this one. This is otherwise my patient. This is the normal side. We can see there's a very, very slim band of the extensor tendon which insert here. And this is the diseased side. So with dynamic maneuver, we can understand that there is the point of the rupture, and there is this is the distal stump. This is the normal tendon gliding at this level. For rotator cuff tendon, for example, I wrote here infraspinatus, but with dynamic maneuver, it's clear that here there is no more tendon. These are debris or synovial tissue, but not tendon. The teres minor is otherwise the only tendon that can be found in this massive cuff. Okay, there. Ligaments. Boxer knuckle is referred to an injury of the sagittal band at the level of the dorsal metacarpal head and the metacarpophalangeal joint. It helps in the stability of the extensor tendon, and when it breaks, the tendon may luxate. Usually we see this injury in boxer. Otherwise, we can see in male adolescents who have a punch at the level of the wall just because they are angry. So this is how to check for this kind of injury. Use a good amount of gel, have a transversal sonogram at this level, and have the patient flex and have have a fist position. Okay, so during flexion, the tendon subluxes here. Okay. The dorsal scapho-lunate is an important ligament for the stability of the wrist, and it can be easily found with axial sonograms. You just check for the listed tubercle, then just go a bit distal, and you can see the scaphoid and the lunate, and there is the the dorsal scapho-lunate ligament. In this case, it's not so easy to tell if there is a complete tear. It seems that there is a tear, but I'm not so happy with the static image. During dynamic maneuvers, also in flexion extension, but also in radial and ulnar deviation, we can understand that there is a dissociation between these two structures, and there was a completely rupture of this ligament. The ventral ligament is a bit difficult to be seen, but in this patient was normal, and this is the other side, and during dynamic maneuvers there was no diastasis, there was no problem here. This was a 19 years old patient with limitation in flexion and extension of the wrist since 1 year, post-traumatic, sorry. He hasn't done any imaging modality since this moment, in which he had ultrasound and X-ray. At X-ray, we can see there is a problem here with the scaphoid, but I think that ultrasound is very, very nice to demonstrate the pathology. This is a volar sagittal sonogram in this view, and this is the distal radius, this is the scaphoid and the trapezius. Here we have the flexor carpi radialis. In this view, I say that the normal scaphoid resemble something like a bell. Here at the diseased side, we can see a broken bell, and during dynamic maneuver, this distance increases. The patient also had a lesion of the scapho-lunate, but the main problem is here. He had also a CT evaluation, and we can understand that this is a pseudoarthritis pseudoarthrosis in a previous fracture. Ultrasound is particularly nice in demonstrating the ulnar collateral ligament injury, and in particular Stener lesion, which are important to be demonstrated because there is a need to, they usually have a need to go to surgery because they don't heal. So I think this was the first article reported in literature in which this technique was presented. And basically the adductor aponeurosis is connected with the extensor pollicis longus. So it lies superficial to the ulnar collateral ligament, and during flexion and extension of the distal phalanx of the thumb, we can nicely demonstrate that this aponeurosis glides because it's in connection with the extensor pollicis longus. So this is what happens normally. In a Stener lesion, otherwise, the ligament is torn and is retracted. This is the static image that we see, and we can image that this is the what happens. So this is the torn ulnar collateral ligament and the adductor aponeurosis. Dynamic maneuver confirmed that the adductor aponeurosis is no more located superficial to the ulnar collateral ligament. So let's check again this case, and we see this small structure here, which glides over the ligament. Here, the structure arrives here. So there can be healing because to interposition of the adductor aponeurosis. This patient had to go to surgery to correct the problem. Otherwise, there can be no good healing. This is the same patient. Climber finger refers to pathology of the pulley. We've seen before trigger finger, climber finger, the pulley broke. This is the normal, the pulley that broke are A2, A4, or A3. This is a normal A2 pulley. We can see that the flexor tendon are very near the phalanx, the cortical bone. Okay, in pathological state in which the pulley is broken, the tendon can be seen distant from the cortical bone, and this distance increase during flexion. Okay, so we can nicely demonstrate it. I'm at the end of my presentation. Please always listen to patient story and symptoms. So Messi is asking what? Let's see. This is a 19 years old girl who came to me sent by a rheumatologist because she has some pain at the level of the middle third of the arm. She was already been seen by other colleagues, but no, there was no diagnosis. So she thought that she had no rheumatologic problems and told me to have an ultrasound examination to check for something that may cause the patient problem. So I don't know if you can see it, but in less than 1 minute, I see the long head of the biceps, subscap, supraspinatus, the cuff in the short axis, the infra, the acromioclavicular joint. So everything is normal. But the patient I have some pain here, and if you press here, something irradiate distally. Okay, let's try to see. And we put our probe here and go down, and we see this structure. There was no hyperemia at color Doppler, and it was on the course of the radial nerve, and we suspected a neurofibroma of the radial nerve. Of course, the patient had also a contrast enhanced MRI, which confirmed the suspect. She underwent surgery, and it was effectively neurofibroma. This is a 47-year-old man that 1 month earlier felt a pop at the level of the posterior ankle. He was referred for persisting pain, limitation in plantar flexion, and increasing leg swelling. So with ultrasound, we can nicely demonstrate that there is an important complete Achilles tendon tear. We can also measure the point of the tear, and so the diagnosis is Achilles tendon rupture. But the patient referred something. So if we listen to the patient, the leg, the swelling of the leg was increasing. So we go up and we see this at the level of gemellar vein. We see that there is a thrombosis. We confirm it, there is no flow at color Doppler, and now I'm just going distally to confirm that this is the same patient that we've seen before with the same rupture of the Achilles tendon. So yes, it was Achilles rupture, but complicated by vein thrombosis. And in this article, by Delgado. He said, he wrote that DVT must be kept in mind. This is for tennis leg, but also, in my opinion, in lesion of the Achilles tendon, and venous structure of the calf should be examined. This is the same patient 1 year later. He came for shoulder pain after a motocross fall 3 days before. He had not an X-ray imaging investigation, because the last time I made the correct diagnosis, so he thought, okay, he can manage the case. So he came to me. The rotator cuff was normal. He referred posterior pain. He may have some movements, so mobility was conserved, I think. But end of the examination, I thought no, because of the story of the patient. So I just go posterior with, these are mainly sagittal and axial sonogram. This is the healthy side at the level of the scapula and the spine of the scapula here. Here we can find something strange, and let's see. This is what I found. So in a sagittal view, there is this cortical irregularity. This is the normal side, and the cortical irregularity of the scapula was even greater in this view. Sottospinato means infraspinatus. This is the normal healthy side. So I thought to have a CT scan to clearly demonstrate the problem, and these were my corresponding to this. I didn't imagine that the fracture was so big. Luckily for the patient, the fracture was extra-articular, and the glenoid was not involved by the fracture. Just to say that not only ultrasound, this is a recent article, and this is a very nice video clip from this article. This is very nice, but I think that we with ultrasound can see this gliding in 5 seconds. So I think that ultrasound has many advantages. We have to remember that it has some limitation, but if we know what are our limits and our strength, I think that we can make many good diagnoses with ultrasound, and we can be more and more enthusiastic about ultrasound. And thank you for your attention.
Thank you very much, Dr. Marco. That was a very comprehensive dynamic MSK ultrasound examination. I really appreciate you for your precious time. And I know you are very busy with all of your patients. And let me just ask our attendees if you have any question. Any question from any of you? Maybe you have covered very well the subject, and there's just a lot of nice images that actually kind of depicts all the anatomy, and especially the abnormality that we see in our patients. Very, very nice one. So any question from any of you?
None, Dr. Jim, but we're very thankful also in behalf of all of the other attendees. Dr. Marco, thank you very much for a great lecture. Grazie.
Thank you, Dr. Marco. What time is it in Italy?
It's I think 3 p.m. 3 p.m.
Okay. Nice one. So I think there are no questions, and you have basically covered everything. Very nice. So
Thank you.
yeah. Yes.
I know there are these are mainly practical example that I've seen during my practice. So the meaning of this lecture was there is no limit to what you can do with ultrasound, and remember that with the patient with you, you can make some diagnosis basing to the history, to the clinical examination. So so this is the meaning of this presentation.
Yeah, I think that you're right. There are a lot of times when we miss listening to the patient, when the patient is already giving us all the clue to his problem. Yeah. And it's very nice that the ultrasound can actually confirm it. Yeah. Yeah. So again, Dr. Marco, really appreciate your time. And I would like to thank you for joining us in our mask ultrasound Zoom meeting. And hopefully we can have you again next time. And really, really thank you for this very important lecture. Yeah. And please take care. Always.
Thank you. Yeah. I hope my English was good enough. I'm sorry if my English is not so so good, but I hope everything was that you could understand everything.
Yes, yes, yes. We understand everything.
Thank you.
On the contrary, doctor, it was very good. I just think that you gave us a very comprehensive lecture, so it was something that we truly understood, and the visuals was amazing also. Thank you so much. Grazie.
Thank you. Thank you.
Okay, there's one question here though. How to treat snapping syndrome? Maybe he's referring to the shoulder.
I have
hip or shoulder, I don't know. Can
you clarify? Sorry, can you understand me?
Yeah.
I have to say that I usually don't treat patients, so I refer to other colleagues. So probably all of you, if you have experience in treating, are many times better than me. For example, what can I say is that for the snapping hip cases that I presented, I think that in these cases, the patient want to know what's happening. So if you explain and if you can manage to have the patient see what are the structures that are snapping, and you can explain to patient that there is really no actual problem in this snapping. I think that many cases don't require any real treatment. Otherwise, symptomatic patients are different.
Yeah, I agree. So I think there are so many approaches to treat snapping syndrome, and we can really see that we have to also identify what really causing it. Could be a bone, it could be a fascial thickening, or it could be a tendinosis, or it can be any of those things. Yeah. So thank you again, Dr. Marco, for your time and for your great lecture, and hope to see you soon. You take care. Yeah,
thanks.
Thank you. Regards to Federico.
Yeah.
Which?
Yeah.
Okay. Thank you. Thank you. Yeah. Bye.
Bye.
Bye.